Hello, everybody, and welcome to the ReAligned Healthcare. With us, we have Joshua Liu, who is the founder and the CEO of SeamlessMD. Josh, welcome to the podcast.
Thanks for having me.
Josh, you've been pretty active on social media in talking about how do you build digital health startups and how do you actually work with healthcare system to produce the maximum value. So maybe talk about the building process a little bit more, and in the meantime, talk about your story.
So, born and raised in Toronto, Canada, and I've always been a builder in different ways. So when I was in, let's say, high school, I was building not businesses, but school clubs, nonprofit groups, stuff like that. And when I got into medical school, I still had the itch to build stuff, do projects. And around the time of my third year of medical school, I started hearing about startups and technology. Now, this is back in, let's say, 2011 or so, around that time. And I actually had a couple of friends from med school who were also interested in technology. And so we actually tried starting a totally different healthcare tech venture while in med school. And we quit/gave up after maybe 4 to 5 months because we were all clinical people. None of us had the skill set to code or, build the product or build a business, and gave up on that. But in my last year of med school, I still had the itch to build something. And just by chance, I applied to a local startup incubator on a whim, met a couple of brilliant engineers, and we decided to go and start a company to build technology to improve the patient journey and health outcomes. Long story short, I graduated med school, got into residency, and instead of doing residency, I decided to just try building the company full time, thinking it's probably going to fail. And then I would just go back and do residency a year later. And 12 years later, I'm still running the same company. It became my full-time gig, and it's been that way ever since.
Wow. Interesting story. And you certainly had a bigger impact than the individual. And I think that's for a lot of us who transition more from day-to-day practice. A lot of the transition is to see if you can actually scale your knowledge across the institutions. So now you're doing this, right? And you're doing it for a good decade, right? And a lot of your posts are like, how do you create a value? What specifically stuck to me is the amount of venture raised not really correlated with the value you'll produce for a healthcare system, or actually, even your success. So let's start with that. Like, our topic is ReAligned Healthcare. If you raise too much and you couldn't really deliver value, that sounds to me like wasted resources that need to be realigned.
Yeah, I think one of the lessons I've taken away, and maybe I'm biased because we did not raise a ton of capital, and to be fair, my story is an N of one experience, right? But what I have come to believe is that scarcity breeds focus. And I can tell you that, we've raised, a bit more than 7 million in investment capital lifetime, which is not a little bit, but not a ton, compared to a lot of other venture-backed companies. And I can tell you, let's say 4 or 5 years ago when we had a fresh capital round, and you can imagine, like, even back in 2020, there's still a lot of, thinking that, hey, you have to grow at all costs, just keep investing in growth as opposed to sustainability and profitability. Because people thought that, well, if you just grow the business, even if you're unprofitable, you'll just raise more venture capital money and you'll be fine. And obviously the world changed in the last couple of years, and now profitability really matters, whether in healthcare or any other industry. But even before that change happened, we actually were a bit earlier on that curve of, hey, you know what, like, we shouldn't assume that we can just keep raising capital forever. We have to be sustainable at some point. And when we made that transition internally, I think one of the things that we realized was that actually when you've decided you're going to have scarcity in your capital resources, your people resources, you start to recognize that there are just a lot of low ROI things that you're doing, whether it's, on the business side of things or the product side of things and whatnot. And when you just get rid of all the stuff that's low ROI, low value, you're able to pinpoint the things that add the most value to your health system partners, your patients, your business, and you actually can move faster. And I think what happens when you probably raise too much capital is that you do too many things. You feel like you're under pressure to just hire people for the sake of hiring people so that you can show that you're bigger, you have more employees, you can do more things, but then you're just completely disorganized, your efforts are fragmented. And so now I just really believe that scarcity breeds focus. And when you're focused and you apply more intensity to a focused, path, you can accomplish so much more, not just in healthcare, in any sort of venture.
It certainly makes sense. Do you think it's scarcity or focus? Because it's almost sounded like, based on your description, especially of the high high value startup that just raised the big round, you came and possibly asked for way more than you need, right? Like you couldn't really justify, which means maybe you didn't really have a full plan to execute on that, like from the product perspective. And now you got all the money, right? And you need to create believable plans for your venture partners. How are you planning to raise this? So you create the projects that may not yet been fully validated, just to kind of show the rosy parts. And that's what leads to a lot of hiring, right? Like you're figuring out that, like, I'm gonna out hire myself out of this mess. Like I'm gonna out hire through the technical team. Let me just bring technical people and they will build a best in class something, or let me bring clinical people, because of course if you get a random doctor that's applying your position, they will definitely know how to sell the healthcare. And then on top of that, you're hiring your salespeople, right? Because now you need to do this. So, which bring me to value part. Like in your journey, like, because you're one of those people who constantly talking about generating value, being staying true to the needs of healthcare system and the customer. Like, what's your process? Like, how do you talk? How you discover? How you even decide what to build, right? Because when you talk with 5 physicians, you'll get 5 proposals what need to be built. Like we never could come into agreement.
Yeah, I think what we've come to believe is that instead of asking folks what solution we should build, we should focus more on the problem to be solved. And then from there, we'll figure out what the right solution is, regardless if it's what the solution, our clinical partners think. If we can align on what the problem to be solved, we can come up with the best solution. And I think when it comes to understanding what the value is, the big lesson for us has been we have to trust yet verify with multiple stakeholders in these large complex healthcare systems. So for me, one of the most challenging stories was, I remember, let's say maybe 7 years ago or something like that, we had done a couple of hospital pilots and we had found these fantastic clinical champions who told us, and by the way, the story I'm going to tell you was repeated at more than one institution with different stakeholders, but same concept. We would find a great, clinical champion, and they would say, hey, Josh, if we pilot your innovation here, and if we reduce readmissions in half, trust me, our administration will buy into this. They'll fund this long term. They'll see the value of this. And as an outsider, that makes total sense. Readmissions are bad. They cost money, et cetera, et cetera. So we'd spend 6 to 12 months implementing our solution, doing these pilots. We'd measure the results, and they would reduce readmissions by over 50%. Everyone's all excited. And then we'd go and finally co-present the results to the hospital CEO, the leadership team, and our champions, and everyone's there. And the CEO would say, wow, these results are amazing. This is clearly great for patient care. But, given the way that our hospital was paid by, let's say this was in Canada, by the government, we get a global, budget from the government. And actually, if we save money doing this, they think we need less money next year. So this actually does not create a financial ROI for the hospital. So even though I think this is good for patient outcomes, I can't justify it economically. And that just blew my mind. And I think that the big lesson I had was, well, This is why we actually have to engage the funders, the administrative stakeholders up front too. Because if I had asked the CEO, well, is reducing readmissions a priority for you? He or she might have said, actually, no. But if you help me reduce length of stay and lower the cost of care, that I would buy into, and then that would probably change our approach and the problem identification in the first place. But we didn't realize that there was that disconnect between what some clinical champions thought was valuable for the institution to pay for, and then what the actual person writing the check valued. And of course, the hard part is, as you and me, as both clinical people, we don't just only want to build things that improve finances. We want to improve the patient outcome. And there's that disconnect that we know exists in healthcare sometimes between what gets paid for and what actually helps the patient.
This is one of the most vivid examples of clear misalignment. Because frankly, it's not helping literally anyone except maybe hospital administrator who keeping the budget, right? Like patients do not want to be there. The government possibly, most likely, have a better way to allocate resources. So frankly, finding out the way to ensure that you're not penalizing hospitals, like, because it's very easy to blame bad CEO, right? But in reality, the system is penalizing hospitals for decreasing utilization, right? And that's more than just individual contributor. It's more of a systemic measure. So, okay, and it makes sense. And frankly, especially for the young innovators, that's what you very often see. You grab one part of the elephant. There is someone who's been practicing for 30 years and then with all conviction telling you that you need to do A, B, C, D, right? But unfortunately, very often that's maybe just rule sets of playing the system, not necessarily something that you truly want to build. And that's especially true right now for the world of artificial intelligence, because we maybe keep doing the same stuff, just more, autonomously, with even more rigor from AI. And this will definitely not help anyone, because now you're potentially automating even the worst decision.
What I was going to say, you're absolutely right. I mean, AI is going to accelerate the automation of whatever the existing current state is. In fact, you could argue that AI is going to reinforce the status quo, which may not be good if the status quo actually is not great, right? So we're hoping that we can actually re-engineer a lot of the stuff that doesn't make sense in healthcare and then automate it with AI and other technology. But if we don't re-engineer the things that don't make sense, we're just going to accelerate the stuff that you, quote unquote, is broken.
Let's stay more on this topic. What I'm seeing is now we're actually starting to hide even more processes under the rug, right? So we already had a lot of unknown black boxes. Like I have some workflow happening here that's fax related or some of the things, and now I automated some of this. So I created yet another black box on top of a black boxes, and I'm starting to see absolutely ridiculously crazy workflows where fax to fax communication going through the optical character recognitions to put in some of the agentic flows, where we putting legacy technology that we tried to substitute and didn't completely push out with our API to API integration. And we put even additional redundant clinical workflow, prior auth, rejection, or anything else on top of the automated legacy workflows. So how can we fight this? Because no one certainly in this, like we're talking about ROI, right? And I think that's where I'm trying to push you, because on one hand we have, let's bring as much ROI as possible, as fast as possible to healthcare systems. But very often bringing this require us to actually automate the processes that frankly need to be redesigned, and maybe even from two sides, before they can start bringing ROI, which actually through the redesign process may mean that you actually have negative ROI, right? Because you're rediscovering the process, you're trying to come up with something new. So how do we fix with that? Like who pay for this innovation?
So it's funny. Before the rise of AI and agents, I think there's a lot more motivation to re-engineer and redesign these workflows because they were so cumbersome. But to your point, like very very hot example right now is with ambient and AI scribes, right? And so everyone hated documentation, took up way too much time. But if now with ambient and with AI assistance, you can streamline documentation, right? To the point where maybe you forget that it's there, right? There's no mouse and keyboard in the room, and then as clinicians, you don't care anymore that documentation exists because you don't have to do as much work. Um, Maybe then documentation still in its current form exists. Whereas if we didn't have ambient, um, you would actually have to be motivated to redesign. Maybe you'd actually get rid of documentation in the first place. Don't even make it a requirement, right? So, and now the point that they were getting at here is, well, with AI agents, right? So like in the past, you would say, hey, like let's make things more interoperable, right? It takes too long to like manually move data around. Okay, if I can just hire an agent to basically manually move data around without me having to see what's going on, then why would I redesign the process? And that's fair. Like, why should we care to redesign it? I mean, there's probably reasons why, but in the short term, there's less of motivation to do it. As long as the cost of compute and using AI is cheap enough, you can just get agents to do all these dumb workflows. And don't you have bigger problems to fix then?
Maybe. Like, I think it's a great philosophical question because, like, let's go into, for example, discharge summaries, right? Because for the long time discharge summaries or, your note, you will send it, and very often that would be the only source of information, what's happened, right? Like you will not even receive CCDA or anything else. You'll just get this. And even insurers and other clinical providers, they would scan it and manually abstract and enter the information. But then we had interoperability standards where say, yes, but please don't do all of that, right? Like you will get the proper package. And for my interoperability focused mind, this is the good path, right? Like we create the unified network where I can pull everything. I don't have duplication. I have a clear source of truth. But just from the argument's sake, if my agent is perfect and all the information communicated in the note can be properly abstracted, right, with like, I don't know, 99.9% OCR perception, then frankly, do I truly care? As long as I get information, right, and do I need duplicative things? Like, I'm not sure about that. I'm not sure there is 99.9% accuracy, right, because OCR is by no mean and agents are very fallible. But I think it's a valid argument that's may stand here. Another thing that's I noticed, and you started talking about redesign, is right before all of the ambient craze started, like about, I don't know, 7 years ago, 80 years ago. We're talking about what's a minimal requires for documentation for billing, right? Because a lot of your documentation is required for billing. We don't talk about this anymore. How much doctor need to document to truly justify care? That's we don't, and we talk about optimizing the notes for clinician comprehension. It's like, how do you exactly need to go from SOAP to APSO or things around that, or maybe what is generated. Like at some of the notes, we had a project. We put like generated content, and a lot of the generated content will be just like signal for primary care physician, just like do not read unless you're truly interested. And we don't really do any of that anymore. Why? Because now pretty much everything is generated content to a certain degree, and the amount of traction that ambient got is high enough for us to actually allow clinicians not to push back on the documentation templates, especially if they can just go and fill those templates with the voice. But do you think it's a good path? Because, to my previous question, someone still have to pay for inefficiency, right? And right now, which mean we just trading our inefficiency to some of the compute costs, and we assume things are good, but can it harm us in the long run?
I think conceptually it should, right? Because you're right, someone's paying for that inefficiency. And it feels like if you compound enough inefficiencies, something could break at some point, and then you're going to go back and fix it. I just don't know if anyone's going to be motivated to fix any of these things until something actually breaks and there's a consequence to it. I mean, that's the whole thing in healthcare, right? Like, no one's actually going to move and change things until there's some material consequence. And I think we'd see the same thing here.
So from that perspective, how are you guys trying to be different? How are you guys trying to ensure that when you provide value, you're not just abstracting inefficiency and charging for it, but actually truly deliver the value? Like, what's your process? What's your secret?
Yeah, well, maybe I'll back up and just give it more context for the problem space we're in, how we solve it, and I can get more to answering your question. So, to explain what SeamlessMD is and does, the analogy I like to use is travel. So imagine you're, traveling from point A to point B. In the past, you had paper maps. Now you have GPS, and yes, I guess now we have autonomous driving too. But that aside, you have GPS. It's faster, safer, better. And what I love about GPS is that, when you were falling off track, it would alert you and then it gets you back in the right direction. What struck us about the patient journey, whether that's going through a surgery, a cancer journey, chronic care journey, we still give patients lots of paper and verbal instructions, which they forget, they lose, and they find hard to follow. And the care team doesn't really know what's going on with the patient, especially outside the four walls. And so we basically said, well, why don't we actually build essentially a GPS to navigate a patient through complex healthcare journeys? So imagine you're going through a heart surgery. With SeamlessMD, you get an application on your phone, tablet, through your browser, and you're navigated with reminders of what to do before your heart surgery. So when to stop your blood thinners, when to stop eating and drinking after your surgery, what are all the rehab and recovery exercises and action items I should do when you go home, tracking your health status, your symptoms, your pain levels, photos of your surgical incision, and then making that data available in dashboards embedded in the EHR so your care team can catch issues earlier. And ultimately, we've helped health systems lower length of stay, readmissions, ED visits, cost of care, mortality, and so forth by building this GPS to navigate this patient, and then it almost like a radar system for the care team to catch things earlier. And I think what's been interesting is that we're not like the only company to come up with this concept, let's call it 12 years ago, and not the only ones who have tried this since. But I think what we've done differently is that a lot of other companies took a very tech-focused approach to the problem where they just tried to build, more and more features and try to make this totally self-serve technology platform for health systems. And we took a different, very clinical approach. We're very hands-on with our health system partners. On top of the tech, we have all of these clinical content pathways for different conditions and procedures that we basically have built a team that's 25% clinical, so that we were able to not only pump out all these different clinical pathways and content on the platform, but we actually work with frontline clinicians to customize and configure the pathways to match the protocols that they want their patients to have. And I think that's been the key insight, which is the tech is kind of the easy part. The really hard part has been actually how do you deliver the right clinical pieces at the right time in the patient journey and keep the staff engaged with the platform so that they're getting the most out of the technology along with the patient. And most companies, I think, have just been too technology focused and not clinically focused enough, which is why in our space, very few companies have actually delivered outcome results and delivered evidence. And so I think the secret sauce has just been like intentionally designing our team like a health system where there's just a lot more clinical DNA compared to a traditional technology company. And I think that's been the biggest difference. It's the DNA of the company, really.
Mm. So design not only to be used by clinicians, but actually continuously co-designed by both your clinical team that's know and understand clinical and your pilots and your colleagues that's been deployed on other sites. I like that. When you talk about, like, you mentioned, you hired a lot of people, you generate a lot of content, right? Like, I cannot not to ask it right now, right? Like, we are in a generative AI craze, and a lot of the content generation got easier, and sometimes, even looking at the instruction or professional case managers used to create compared to what ChatGPT can generate. Like, we clearly see how superior ChatGPT is. Like, did it affect at all? Like, have you ever looked at the tool and say, like, oh boy, I wish I had it 7 years ago? And how do you use it now?
So what's interesting is, I'll tell you where we are and aren't using generative. We don't still don't use very much generative for producing the initial content. Um, or I mean, my team might be using it a little bit, but for certain things, but I don't think a whole lot. I think where it's probably most useful is if you're trying to translate the content to be more health literacy friendly. If you want to make something at the grade 6 reading level, I think you can do that a lot faster with generative. But it's partially because I love the way we design the content. We then fit the content into specific features and components in our platform. Um, Generative alone won't be able to do that because we still have to manually adapt it to our platform. And then the other piece is that we work directly with the clinical teams at our health system customers to further configure it to match their protocols and workflows. So you can use generative to create all the pathway content you want in the world, but who's going to do the clinical change management to get all the physicians and nurses and OT, PT, everyone in the room to align on, you know, what should our version of the pathway be for our patients? And that's the part that technology can do. You need a human to do that clinical change management and get alignment on this is our version of the pathway at our health system on the platform. Um, I will say where we're using generative is when it comes to translating the pathways to different languages for patients. In the past, even though let's say Google Translate has been around for years, maybe decades now, health systems that we work with didn't trust those translation engines to translate the languages, so they would always basically hire a medical transcription company or an internal translation service at the health system to manually translate all the clinical content into Spanish or other languages, and that's very costly actually. What we've done is that we've actually embedded language translation generative AI into our backend, where we can actually one-click draft the translations of the content in different languages, and we've tested it. It's actually quite good now for a number of different languages. We still encourage health systems to proofread and sign off on the translated versions, but it's cut the cost down dramatically compared to what it was, just a few years ago. And so it's not the sexiest use of generative AI in healthcare, but it's incredibly practical, especially when margins are so tight in health systems. And access is so huge for these populations that don't speak English as their primary language.
I like this kind of use cases. Why? Because the bread and butter, that's what make your margins, not the futuristic AI care delivery pod. Um, so, Josh, right now, where you look at the way you work with healthcare systems, right? What would you tell, like, if you can send a message to yourself 12 years ago? What would be the message?
Yeah. I think one of the biggest messages is just spend as much time with your health system partners as possible. I think one of the things that I've come to learn is that healthcare is very much a relationship based industry. Um, it's funny when we go into, let's say, a competitive situation with the health system, competitive as in like they're looking at several vendors to partner with. Everyone tends to focus on let's create a matrix and compare features and standard checklist things. And then once we actually work with them, and if we ask them 2 years down the line, hey, I'm just curious, like, what's your favorite thing about SeamlessMD? The answer is never, oh, I love this feature or I love this part of the product. The answer is almost always, I love the people, I love the team, we love working with you. And the other thing that I find is that in healthcare, especially, the best way to grow, the best way to market is not really the company doing lots of self promotion. It's when your health system partners are successful. It's when they're the ones presenting at conferences. They're the ones putting out their own, you know, press releases and stories and publications about the results they've achieved. And so I tell myself, look, spend as much time as possible with health systems, make them incredibly successful. It's a huge industry, but it's a small community. Everyone talks. And if all you do is just spend as much time with them to make them successful and deliver value and improve outcomes and create ROI, the word will spread. And you don't have to spend millions of dollars on marketing that won't work. Your best marketing is making your partner successful. And I think that's generally true in most industries, but I think it's especially true in healthcare.
But this long, Josh, and if you
Yes.
raise big round, you cannot wait that long, right? Because you need to go to organization, you need to make them successful, you need to actually convince and do something that they will want to put their name next to, not only on your white paper, but actually on their own personal presentation too. Like of course, this is a sarcastic one, but I just like I wish everyone will follow this path, but that's very hard for 18 to 24 months funding cycles.
Well, it's true. And I think that's why one of the things I believe is that for many, many innovations in healthcare, it has to be a patient process. It has to be a long game that you're playing. I mean, look, there's a few exceptions where the market pull is so strong that you can actually grow very quickly because the demand is high and you can maybe use that venture capital money wisely. I mean, if you look at the last couple of years, like if you're in the ambient space right now, I think it does make sense to actually raise a fair bit of money and capitalize on all the demand. You probably should. But for a lot of innovators who are not in product categories where there's insane demand for their innovation right now, you can raise all the money in the world that you want, but you can go to every conference you want. You can be on every panel at Becker's. You can be in every magazine. You can be on every ad, but you can't force a health system to buy. They'll hear about you, but if the demand isn't there, those marketing dollars, you're not going to see a return on that ever, if not for years. And so, that goes back to why I've come to believe that, like, look, when your resources are limited, you start to really think about, like, okay, what actually drives value right now? Like, what's the 20% of stuff that creates 80% of the value? And you can evaluate that in your marketing, in your sales, in your product, and everything else. But yeah, if you're an ambient company right now, I would say go wild. The demand is there. You could justify it. It's true.
Yeah, I think it's a whole another episode, hopefully with ambient, because at this point, I'm not even sure that makes sense to raise money because everyone already raised so much, right? And it's more of a run to the bottom right now. Or how fast can you switch to ambient plus, which pretty much not ambient, which is other documentation, revenue cycle management, or CDI or something else around that. So yeah, we'll see. Maybe some of them become EHR themselves because people are asking questions. What's the role of the EHR if your documentation and billing been done by automated agents?
Well, here's my question for you. So, before agents came along, I think a lot of the ambient companies, their vision was, hey, we're going to start with, scribing, and then we're going to start adding in all these things around coding and rev cycle and all these things. And eventually they believed that voice would be the brand new interface between the clinician and the operating system, and they'd have a wedge to eventually displace the EHR. I think that was the big vision that they had, or that they sold at least to investors. And now that agents exist, I almost feel that that reinforces the stickiness of the EHR, because if you could just have agents navigate the EHR, no matter how inefficient and no matter how many clicks it would take, you don't have to do that anymore as a clinician. And so I almost feel like agents actually make the EHRs stickier going forward, which hurts some of these other companies that were hoping to displace them and be competitive at some point. we'll have to see if that's true. But like, if, I don't know, if I'm Epic, I'm like, I'm going all in on agents. I'm gonna help you build as many agents as you want to navigate the EHR, and make you continuously reliant on us. It feels like to me that's the right play if I'm an Epic or a Cerner or a Meditech.
Frankly, I enable as many meaningful agents as you or my partners, right, can build. Like, I mean, Microsoft's, for example, right, or Oracle for Cerner. For this, I'm not sure about sticky. Like the stickier part about the EHR is amount of investment healthcare system already made into that, right? So like when you invested billions of dollars, it's not even the question because the switching costs are still super high. Like I don't really care how fancy you are right now, but my risk and my costs are so high that this is not even realm of possibility for me to consider. And we'll see what's going to happen because some of my colleagues working in the venture capitals mentioned that agentic things are changing everything, and agent and healthcare is almost solved to a certain degree. I think this is, pardon my language, BS.
Me too.
Because a you can't solve healthcare and not with engines, right? Because our tails are so long, you can't really solve it. And B, for God's sake, like we're talking about recall in a long of a context for the models, right? Like our medical charts sometime being way longer than the context window. I'm not even talking about the ability to recall and amount of a confusion that agents will encounter and ability to multiply errors. It's just not something that we're ready to solve. Like, is it in a fairy tale land? You can imagine if every piece of technology worked perfectly, is it solved? Absolutely, yes. But so the people in 1950 and 60s, where they're like, oh, we have a artificial intelligence coming, so we likely will have flying robots in the 10 to 20 years from now. So I think to a certain degree this is very harmful for both clinicians upfront, patients who may be hoping for too much or too little, or even people who going into the medicine and someone saying, you know what, no, don't go there because in 10 years robots will be doing all the surgeries and delivering all the primary cares, and it's kind of solved field, right? And the EHRs are. So going back to reality, EHR is here. EHR is gonna stay. At least for the next decade. No doubt about that. We likely will augment them and we likely push them to be way more open. But you certainly have a lot of experience working with EHR. So tell me and tell the listeners, like, what's the secret sauce? Like, what's the best approach to start working with EHR to ensure you're maximizing the value for your partners?
I remember years ago when we didn't have any EHR integrations done, we would try to just email, we'd call, let's say Epic or Cerner, and we'd make the same pitch that every startup makes. We'd try to say, hey, our product adds value to your customers. It seems like a no-brainer that you should integrate with us. And we'd get crickets. No one would ever respond. And we just naively did not understand why. So without that, we'd have to just keep working with health systems with a completely standalone product. And then when things changed was when we had our first, Epic and Cerner, clients say, hey, this Seamless is great, but this would be a lot easier if we had it integrated to streamline some of these clinical workflows. And so when, we had one large health system for each of Epic and Cerner go to them around the same time, actually, and say, hey, we actually want you to get Seamless into your relatively new app store ecosystems that they had back in 2017, 2018. All of a sudden, Epic and Cerner would pick up the phone and say, okay, well, now that you have a customer asking for it, sure, like we'll do it. And like looking back, that's just incredibly rational then. I mean, of course they will listen to their customers. Why would they listen to us, a random company they've never heard of? And so the advice I give startups now is like, look, get a customer saying this is valuable and then go advocate for you with, let's say, Epic or Cerner or Meditech or whatnot. And that's the best way to make it happen. Now, I think to be fair, it was easier for us back then. This is, let's say 7 years ago when there were fewer startups, there was less demand on these EHR vendors to integrate. So I think we're a bit lucky that we got involved with them at a time when there weren't that many asks. Now it's just crazy. I mean, you might remember like Epic had the App Orchard back then, and then they actually had a lot more support for those companies, and now they're like, okay, there's too many of these. Like we don't we don't have the time or space to have the App Orchard. So then it evolved in a few different ways the last few years. So to be honest, I don't know how hard it is now for a new startup to get that sort of validation from, let's say, Epic. It's probably a lot harder now than it used to be, but I think the answer is still true. If you get demand from their customers, enough demand, whatever that amount of demand is needed now, they'll pick up the phone. But you have to earn it. It won't be given to you.
And to a certain degree, that's a catch-22, right? Because for a lot of a startup, is like you're not very attractive until you're Epic integrated, right? And you cannot be integrated until you're attractive. So it's hard, and it's genuinely hard for all of you listeners who currently having a startup. It's a great startup, but you just cannot break into the Epic or Cerner ecosystem. Your only play is to actually find those clinical champions who will take a leap of faith with you and walk the path. It's to a certain degree, it's actually got me a little bit easier, right? Because the vendor services is not App Orchard. So the Epic is not just trying to create their own app store anymore, right? So there is more pay to play right now available than it's used to. Like you at least will be able to get some attention if you pay enough to attract this attention. It's neither cheap nor easy, and then it's not bringing you any success around that. But then there are different level of integration, right? And I think this is something as a startup, you're always kind of have to discuss with your clinician, because being especially on interop side, we always say, okay, is it launching from the Epic context good enough, or I want to get some information in, or I want to get all of my information in, or I want to ensure that everything you generate stored somewhere in Epic, even if Epic may not have the feel for that. So let me create some flow sheets to ensure this information is there. Like, how do you decide that? Like, how much information you currently store in your system versus Epic? And if you store like more in your system, then, how do you build clinical decision support? That's maybe required, based on information you generate.
I think one of the most fascinating things is when you talk to a health system for the first time, and especially a clinician will ask you, oh, does this have Epic integration? And the short answer might be yes, but the actual answer probably should be, well, it depends what you mean by that. Because to your point, you may have a very lightweight integration that does only a few things. You may have a more advanced one that can do lots of things, but then you don't really find out until you get into the weeds of the actual desired use case and workflow. So I think for us,
you may be sending PDFs through the media section, and this is not Epic integration. Please never call this an Epic integration.
So it's one of those. I think for us, it's evolved over time, and it's about, there are a lot of things that we now do with integrations that we didn't even think of just a few years ago. And it's thanks to the partnership of our health system, clients, where, over time, some of them want more and more deeply integrated workflows. And then we just continue to build out more capabilities. And I don't think there's a good answer besides just spend more time with your partners, listen, deeply understand the use case and the workflow, and then being willing to lean in. And I gotta say, as much flack as some of the HR vendors get, when the value is there, they often will lean in and actually work on it with you. And but it has to make sense, and you have to be patient too, and all that. But I think there are a lot of startups who might have this huge vision of, oh, we're going to do all these complex integrations and all that. But I think for us, we just started very small with what did the partner one want? Okay, that's what we're going to do. And then later on, partner two helps you figure out a little bit more, and then it grows. And I think, one of the nice things I think about starting out, earlier in my career, where I was frankly very naive, was that it kind of helped that I didn't have a grand vision for things, because then I was okay starting small. I was okay not being able to accomplish some big vision in year one. I mean, we didn't get into this yet, but it took us 12 months to get our first hospital pilot, you know, off like even approved. So we literally did not have a single user truly using our product for the first 12 months. And if I wasn't that naive, if I had expectations, I might have given up before then. You know, if I
So
were to,
that
yeah.
was 12 months after you build and show the prototype, or like from the time you guys started working?
From the time we started working on the venture, but I can tell you, even from the first pilot that we did, it probably took maybe 9 months from first meeting with that hospital to getting approval to do the pilot 9 months later. I mean, if we knew it would take 9 months from that first meeting, maybe we would have said, nah, no, that's too long, right? But we didn't know any better. We're like, oh, we're gonna get approved next month, and then that became the month after. Then that became the month after, right? At some point, you're just so all in on this that you're willing to be patient, right? That's healthcare for
I
you.
have to say, you guys are lucky that you got 100% hits, right? Even with delays on your pilots. Because death by pilot is real. You may have 5 leads where you're somewhere and all 5 collapse because legal is not there, because security is saying it's a no cost pilot, but I still have to do security assessment, so it's not zero cost to me. Like multiple reasons. And that's really disheartening, right? Like when you have all of this time, you spend years building the product and then year negotiating, and then like there is nothing to show. That's usually where organization collapse, right? And the CEO quit and board have to replace the founders. So let's talk about something more positive, because we went to the dark place. Uh, from a clinician perspective, from efficiency perspective, right? Like the agentic system are here, right? No matter how sophisticated we think they will not be able to drive everything, but they still can drive a lot, way more than we can do before. How do you think like your company, your vision, and overall like clinician workflows evolve? Like if you just have to, predict how those communication with patients will happen in 5 years, 10 years from now, like what's your vision?
Yeah, I mean, so for us, right? So right now, we don't really employ AI in the actual patient journey. So for us, we're essentially right now we've digitized the pathways that have been signed off on by clinicians, and that works well right now. And in fact, I actually so far, when we think about what our health system partners have said, no one seems to want to go the agentic route for clinical patient journeys. There's probably a few outliers that are trying that right now, but most of our partners don't want to go down that route because, from a safety perspective, they still want everything a patient gets clinically to have been vetted by the clinical team, which I think makes sense for now. I think for us, we think long term, it is likely that we will see more agentic experiences for our type of product of guiding the patient through the journey. For us, the question is, well, how do we properly match the urgency of our health system partners so that when they're ready to do that sort of experience, we're ready for it? Because if we just launched a bunch of agents right now, I really don't think we'd get much adoption from our health system partners. And so we think about, well, what are some of the middle ground things in between that could get us to an agentic experience, years down the line? So for example, we haven't done this yet, but we think about things like, well, what if we embed a conversational interface inside our product right now with the patient, where it's called a chatbot like feature, where they can ask questions about their recovery after surgery or navigating a cancer journey, and instead of just using, let's call it a broad LLM and broad data from someone else, we basically use RAG or something else, where we're just training the model on the specific pathways and content that their team has signed off on, so that it's not going to hallucinate the answer. And so it still has that conversational experience, but it gives exposure to the patient and the care team for, hey, here's what we could do with a conversational agent like experience in a controlled setting where you're not worried about hallucination. And that might get folks more comfortable with it. And so we think that might be a stepwise, way to eventually evolve to something more agent-like. I think the other thing I think about is even if you and I are more technology savvy and we're comfortable with agents, unless the average consumer as a patient is using agent like experiences in their everyday life, I don't think they're going to necessarily be ready to use that in a complex patient journey. So, you know, even though you and I might be doing that today in other applications, unless my 67-year-old mom is using agents in her like banking or some other things, I don't know if she would pick up our product and use an agent for navigating her cancer journey just yet. And so I kind of need to see the consumer part play out so that the complex patient piece will be comfortable with an agent. And I don't know when that's going to happen.
To be honest, we'll see with time, right? But I think you're spot on about the consistency, because the reason what I would prefer not to have an agent for some of my care coordination is not because I do not trust or believe in technology. I love technology. Is because I need a consistency. And sometimes, the rigid consistency of a regular communication is still better. Because, like, the interesting question that's, if you guys deploy, would love to study, right, or some of your partners to study, is how much the interaction changes. Like how deep are the new type of questions where you're now not limited, right, by the thing that you have to ask for. Like how deep the patients may actually go with the voice interfaces, especially when they have trust. Because my guess, like personal, is I would go way deeper with that. Like I'll try to ask way more complicated question that I ever imagined before. And that's also mean that my goalpost for a lot of this is like constantly driven from, oh, I just want to answer those questions but with the voice, to, oh, now I need more context. I need to actually help you to not only answer the basic things in a chatbot perspective, but understand this too, like, oh, I possibly need to also give you care instructions and go in more of an interpretation of some of this, because now when they have a trust, they expect it. And this is, to me, already too painfully close to like a care automation, right, and automation of a care management, to the point where, like, I'm not sure I'm very comfortable as of 2025.
The other thing that we've noticed too is that when I think about how I'm using, say, let's say Chat GPT today, for example, when you have let's say an agent or a conversational interface, it's really good when you know what question you want to ask, or you know what directive you want to give to an agent, like do task A, do task B, right? What we found in the patient care journey is there are a lot of times where the patient actually learns passively in ways that they wouldn't have maybe learned if they were only using an agent or a conversational interface. So for example, within our solution, we have like tons of patient education, evidence-based content in the library. And when we look at the data, you have all kinds of patients who just like consume everything at their own leisure, and they love that. Or even us just pushing out basic notifications on a timeline of like what to do and when to do it. Patients are passively, getting that instruction and then carrying out on it. And none of that might be possible if you're waiting on the patient to tell the agent, what to do, or like what should I do next. And so I think the long-term experience might probably be a hybrid of, you want to be able to ask the agent for help or what to do or to learn, but you also need some passive guidance as a patient, and a single sort of experience or a pure agent experience, I'm not quite sure ends up being optimal for a patient. And I think what I've seen happen in our space is you have these pure chatbot agent products where they think like they focus too much almost on the form factor, like, hey, I want to build an agent for healthcare, but agents are only good for specific use cases, and it doesn't encompass everything a patient might need going through a complex care journey. And a lot of basic things like education are actually super helpful, and maybe the agent is not the best form factor for that. So I think we're still learning a lot about like what's the right a hybrid of all these different interfaces that make sense for a patient.
Josh, it's such a great point. I think the chat-based interface is just horrible. especially when you're the person need to discover things. Like, to your point, I would never ever go and start asking all the questions around this. Like, I would not even, think about what to ask, especially pre-op. So yes, please keep this interface. And honestly, I when people talk about the agents, a lot of them talking about the voice or chat agents, like your customer support agent. I actually think about agent very differently. Think of them as almost like a cloud function or something. To a certain degree, those are workflows similar to your robotic process automation, with the one huge difference: the way they're dealing with uncertainty. Is your robotic process automation was awesome for early 2000s, but very rigid, right? Like I'm not clicking here, my interface changed a bit, I don't really know what to do. And the biggest difference with the agent compared to a lot of that is like you actually may create a useful system with 60% certainty here in this step, 60% certainty here, and it will keep using the internal context to figure out the rest. Like, as long as you're like directionally correct, you're actually good. And I think that's what make a lot of the agents, shine. And frankly, I think a lot of agents will shine, under the hood. As like we shouldn't even, like, for example, in your example, is like, okay, can agent define the order of information we show to the patient based on what they learn, how they learn, right? Like their things, and just do it dynamically based on this. Like, possible, right? Or some other thing, like, can I more dynamically rephrase to the different grades if your consistency of understanding is not there? Like, I think people will start be more creative with those machines who are now can do like a very small tasks that's solving a problem you may before you didn't even know you existed for user experiences. And that's hopefully will change the user experience, right? Because it's similar to all of us who going back to early 90s interfaces where like, where are the bells and whistles? Where is everything that I expect things to do, right? Or Word that's automatically autocorrect my things. Like, I think we may have a lot of agents like that who will just like nudge you and help you to understand things. So it's not one off, but I absolutely like your dislike for the chat-based interface.
Oh, thank you. But I think you're right in that the power of that is we can have increasingly personalized experiences. And so to your point, you can imagine a future where you can learn maybe the patient has its own personalized agent which can inform us like what their preferences are, what's the best way for them to learn. And to your point, they'll have a very tailored healthcare experience going forward. Obviously pretty far away from that, but I get the excitement around the potential for that. That is completely fair, and it's on us as a company to keep that in mind, to not be complacent either. It's easy for me to say, hey, our thing's working really well right now, why am I going to change it? And then we'll get disrupted a few years down the line, right? So that makes sense.
You at least have 12 months of a pilot leading time.
Yes, that's true.
For the competitors enter the market. In all seriousness, right, we're almost at time. The time flew by very fast. And the traditional questions from the ReAligned Healthcare, you're now been trying to do a digital transformation for almost more than a decade. You're seeing a lot of healthcare system. You helped a lot of patients. What is one thing where you think there are incentives that are misaligned that you think need to change for our healthcare system to actually start to be better aligned with the need of patient societies and clinicians?
I mean, the obvious, but I don't know if it's still the right answer, is like I've for a long time believed in the concept of value-based care and value-based reimbursement conceptually. I think what I've come to believe now as I've gotten older is it's a good example of ideas are easy, but execution is very hard. I want to believe most clinicians would also believe that value-based care and value-based funding makes sense, but they just are really dissatisfied with a lot of the ways that it's been tried. And I don't know what the right answer is for that. All I can tell you is whenever people ask me, hey Josh, like we think seamless is great. How could the healthcare system evolve in a way that would improve adoption of your innovation? And my answer has always been, well, I don't want a billing code, right? I know a lot of these RPM companies really enjoy the CPT billing codes, but my answer has always been, well, the problem is that if you wait for a billing code to incentivize the next innovation, the billing codes will always lag the innovation. Whereas if you incentivize the things that you think matter to improve patient care, then that will pull the right innovation from the market. So my thing has always been, look, like incentivize better outcomes, and then that will force innovators and companies to build products that improve outcomes. But I still don't have a good answer for like how do you actually make value-based care something that's executed well? And so yeah, I don't know what else to say though. Like
Josh, I wish we had a great answer about how to make value-based care concept tick. Like I think we still have a lot of experiments, and I think we'll keep learning. And I think stay honest that it's unperfect system. That's where you need to learn and calculate. Maybe agents will help to calculate more individual risk, right? And help with some part of that. Like hard to say, but I agree with you. Would be way more aligned system, especially when you start reimbursing you for a lot of the value you truly providing. So, Josh, thank you for joining us for this episode of ReAligned Healthcare.
it's been awesome. Thank you for having me.
Thank you, everybody. That was ReAligned Healthcare and your host, Dr. YauheniSolad.